So I'm really excited to be able to present our presenter today. So this is my relative, Melissa Jim. Melissa Jim graduated with her master's in public health at the University of New Mexico School of Medicine in '04. She's been an epidemiologist with the Cancer Surveillance Branch and the Division of Cancer Prevention and Control for the CDC in Albuquerque, the year after. And so she has in her talk, and I think I most recently heard her talk in Buffalo. And so I think having a lot of expertise built up around data linkages, so between cancer center registries and Indian Health Services, and thinking about how that program has been built out, those results have been so impactful that this has become an annual thing for requirements for the cancer registries. So she's also co-I on projects involving linkages for the National Death Index, which is maintained by the National Center for Health Statistics within the Indian Health Service patient registration database. Overall, thinking about how to improve the quality of race data in the death records for thinking about different cancer outcomes. So she's also provided technical assistance and analytical support to the Indian Health Service and other tribal organizations. And prior to working for the CDC, she also worked at the New Mexico Tumor Registry for 5 years. So without further ado, please help me welcome Melissa. Thank you.
Hello, everybody. I hope everyone's doing well. As Mark mentioned, I'm actually originally from Shiprock, New Mexico. And I've been working with CDC since 2005, but never in Atlanta, always in Albuquerque. I do go to Atlanta at least once a year. Am I supposed to be doing these, Mark? There's all these sample poll things.
I can help with that too. Or did you mean slide control or?
Well, I don't know what the sample poll everywhere question slide is.
Sorry about that. We had just a couple more. So that's just reminding people about the poll everywhere. And here, we'll put up that disclosure. And there, now we're on to that first poll everywhere. And then it goes right into the lecture from there.
Okay. So I assume folks are doing something now.
That they are, since they're 100% on, that SICEP is the abbreviation for the Southeastern American Equity Partnership. Looks like they've got the hang of it, and we can go ahead and move forward.
Okay. Here we go. Something I recognize. So I'm going to be talking about what we're doing to improve AIA and cancer surveillance data in the U.S. Just a general overview of some of the topics that I'll go over. I'll just start with a little bit of background information and then talk about the United States Cancer Statistics website, or just in general, and then talk about the methods that we use to improve the estimate of the cancer burden among the AIAN, in particular the IHS linkage, restricting our analysis to IHS purchase referred care delivery area counties, and restricting to non-Hispanic populations. And then I'll go over the USCS data visualization tool. So in the Division of Cancer Prevention and Control, we have 4 different branches. Each branch funds specific programs. I'm from the Cancer Surveillance Branch, and we fund the cancer registries, the National Program of Cancer Registries for CDC. We also have the Comp Cancer Branch, which funds the National Comprehensive Cancer Control Program, and then an Epidemiology and Applied Research Branch, which funds the Cancer Prevention and Control Research Network. But we also have 2 other assignees that are here in Albuquerque that work on improving data for AIN population, and that's Don Haberkamp and Stephanie Melkonian. The last branch we have is the Program Services Branch, and they're the branch that funds the National Breast and Cervical Early Detection Program and the Colorectal Cancer Control Program. We do have some tribal grantees within the Comp Cancer the breast and cervical cancer program, and the colorectal cancer program. So just a little bit of background information. We know that racial misclassification of American Indian Alaska Natives occurs in both cancer surveillance and vital statistics databases. We know that more AIN are misclassified as another race on death certificates than other race groups, and that the results provide underestimates of cancer incidence and death rates among AIN. And this project, which is the National Longitudinal Mortality Survey, what was published by NCHS, they compared self-report census data to race on the death certificate. And what they found was that only 55% of those who self-reported as AIN via the census were identified as AIN on the death certificate, which means that 41% were identified as another race when they passed away. And that's kind of one of the biggest examples of racial misclassification. And then the other thing I wanted to talk about is prior to the CDC MPCR registries, the only AIN cancer incidence data that was coming out was from the SEER program. Now, the SEER program has population-based registries, so they select only certain segments of the population in the U.S. in which they have cancer data. For data from 1992 to 1999, we looked at the 12 SEER geographic areas, and these areas encompassed Alaska, Atlanta, Connecticut, Detroit, Hawaii, Iowa, Los Angeles, New Mexico, San Francisco, Oakland, San Jose, Monterey, Seattle, Puget Sound, and Utah. And they had a total of 818,000 cases. 32% of them were from New Mexico, 21% were from Alaska, 12% were from the Seattle area, and 11% were from LA. And basically what they found was that the AIN cancer incidence rates were lower than the white rate, almost by half, for both males and females. And so historically, we've always heard that cancer incidence in AIN was really low. And that's kind of a mistake, and I'll show you in a second why. So CDC's role in cancer surveillance. We started funding our cancer registries in 1994. This map, all the states in blue are the states that are funded by CDC. There are states in green that are funded by NCI SEER only. And then the ones that are in light blue are funded by both CDC and NCI. Now, SEER has been around since, I think, 1973. MPCR is fairly new. We didn't start funding registries until 1994. So our the first year of data that we have available is 1998. And there's two different strengths for the two different programs. Because SEER has been around so long, they have better treatment data. So when a person is diagnosed in a SEER state, that patient is followed basically from their cancer diagnosis for the rest of their life. Whereas the MPCR registry, the strength of our programs is that it's surveillance. We try to capture every cancer incidence that's occurring in the US. So with SEER data, we weren't able to see what was going on in the Northern Plains, but with the MPCR registries, we're able to get an idea of what's happening in the Northern Plains. And we combine both of the different programs to create the USCS official federal cancer statistics. And next, I'll talk about what we do to improve cancer surveillance data. So the first thing that we do is we link IHS administrative records with both of the cancer registries, the CDC's MPCR and NCI SEER program. What we're trying to do is identify AIN cases that are misclassified as non-AIN. And these results are captured in a field called the IHS link field. in both the MPCR and the SEER annual data submissions. So basically, you could go to any cancer registry in the US and ask for IHS link, which is NACER data item 192. That's the layout that the cancer registries use. And they would have whether or not the cases in their registry linked to IHS or not. Analytically, with these data submissions, what we do is we create a race recode. So we look at race 1, race 2, and IHS link and determine if somebody was not identified as AIAN but did link to IHS, then they get recoded as AIAN. So the race recodes are what you see when you look at different USCS databases, specifically for our USCS AIAN incidence analytic data set, and also the various SEER databases. If you get access to any of the SEER registries, the race you are seeing incorporates the IHS link. And this is how often we do the IHS linkage. So for the states that we link every year, those are in blue. The states that we link every 5 years are in lighter blue. We aren't expecting to link everybody until 2026. And the reason why we only link the states in the light blue every 5 years is because they do not contain an IHS purchase referred care delivery area county in their state. Now, this is what happened in the very first linkage that we did with all the cancer registries. These are the number of individuals that were identified by the IHS linkage. So the blue bar, the dark blue bar shows you the number of individuals that were identified as AIAN by the cancer registries. And the light blue bar shows you the number of individuals that were not identified as AIAN by the cancer registries, but they did link to IHS. So in Alaska, there was only 70 cases that were not identified as AIAN, but did link to IHS, and 3,310 cases in the Southern Plains that were not identified as AIN but did link to IHS, and only 423 in the Southwest. And I believe the reason the difference is so low in both Alaska and the Southwest is that they are SEER funded, and Alaska has the Alaska Native Tumor Registry, who collects cases on Alaska Natives. We believe the 70 individuals are probably American Indians that ended up moving to Alaska and getting diagnosed with cancer. That's why we captured in through the IHS linkage. And in the Southwest, SEER provides extra funding to the New Mexico Tumor Registry to collect AIN cases in Arizona. So they kind of do their own independent linkage before they do the IHS linkage. So I think that's the reason why the cases that are misidentified is so low, is because we're identifying AIN that are not from the Southwest when we do the IHS linkage. And this is what happens to the cancer incidence rates. So prior to the IHS linkage, the cancer incidence rates was a light blue bar. So it shows you there was variation across the regions, and only Alaska had a higher cancer incidence rate than the U.S. non-Hispanic white rate, which is the red bar and the red dash line. Now, the green bar with the green dash line shows you what was coming out of SEER for 1992 to 99. The dark blue bar shows you the cancer incidence rates after we included all the cases that were misidentified as non-AIN. So before, it was only Alaska that had cancer incidence rates higher than the non-Hispanic white rate. But after we did the IHS linkage, we actually found out that the Northern Plains and the Southern Plains had cancer incidence rates that were higher than in the U.S. non-Hispanic white rate also. And the SEER Cancer Surveillance Review AIN data is very similar to the Southwest. And I know we had shown you which registries were contributing to that data set. It's mostly being driven by the Southwest. So AIN cases from New Mexico and Arizona. So that's why the incidence rates were so similar to that region. Next slide. Or I'm doing the next slide. So method 2, the second thing we do is we restrict our data to the IHS purchase referred care delivery area counties. And these are the counties in which IHS is supposed to provide services. So we did a paper where we looked at several instances of the sensitivity and classifications comparing race before versus race after the IHS linkage. This is data from the NPCR SEER data set after we did the IHS linkage. What we found was that sensitivity was better in CHSDA or purchase referred care delivery area counties than non-CHSDA counties. And there's a difference because sometimes administrations like to coin different terms. So when we did the paper, it was called CHSDA counties. Now they're called PRCTA counties or purchase referred care delivery area counties. And we also noted that the classification ratios were better in PRCTA counties versus non. This was for cancer data. We also looked at our data set where we link IHS to the National Death Index. And we've had similar results where the PRCTA counties had better sensitivity and classifications than non-CHSDA counties. And the third data set that we looked at was a data set that did not have anything to do with IHS. It is the National Longitudinal Mortality Study that compared self-reported census data to death certificates. And the results were very similar. The sensitivity was better in CHSDA or PRCTA counties than non-CHSDA. And the classifications were also better, except for the East. And we believe that it's because of the sample size. So the East is the only exception to having better data in PRCTA counties than non-PRCTA. The third method that we do to improve AIA and cancer surveillance data is to restrict to non-Hispanic populations. And basically, in 2000 and 2010, we noticed an increase in the Hispanic AIN population and also the Hispanic Asian Pacific Islander population. And that was due to the way race was imputated via the census. So in 2000, there were quite a few cases that identified themselves as Hispanic but did not select a race. And in 2000, those folks were distributed to the white and Black population. But in 2010, they made a change. So everyone that said they were Hispanic but did not select a race were then distributed across the 4 different groups. So there was a large number of folks that were identified as Hispanic AIN and Hispanic API that did not select a race. And that ended up increasing the AIN population by 115% and the Asian Pacific Islander population by 152%. And basically I have a little graphic that shows you that if the number of cases stays the same, but the population differs, the rate decreases. So what we ended up seeing was a drastic drop in the cancer surveillance or cancer incidence rates by region, particularly in the Pacific Coast. The incidence rate dropped like 2/3. And because of that, we started looking at the number of the population and also the cases, stratifying it by Hispanic origin. And we found that there was a huge difference when we looked at the non-Hispanic AIN population versus the non-Hispanic cases. There was very little difference in terms of the cases. So this is what we found. The dark green bar shows you the non-Hispanic white rate. The lighter green is the white rate, regardless of Hispanic origin. So there's very little difference in the white population when you look at Hispanic origin or not. Now, the dark blue bar is the non-Hispanic AIN rate. The light blue bar is the AIN rate regardless of Hispanic origin. So here you'll notice like it's pretty similar in the Northern Plains and Alaska, Southern Plains, but there's a big difference in the Pacific Coast. And also in the Southwest, but not as drastically as what we see with the Pacific Coast. So what we ended up doing was restricting our data to non-Hispanic AIN, just to try to control what was happening in the Pacific Coast. Now we have an analytic data set that we create. It's called the USCS AIN Incidence Analytic Database, or the USCS AIAD. This database is aggregated by IHS regions. So instead of reporting data by state, we report it by Northern Plains, Alaska, Southern Plains, Pacific Coast, the East, the Southwest, and total US. Our race recode incorporates the IHS link field. We have a purchase referred care delivery county flag, and currently, the current version that we're working on, which is not available yet, has data from 1999 to 2021. We do publish some AIN data briefs. There's a link on where you can find some of those. And then I kind of wanted to go over some of the differences that you'll see on the USCS website. We have a data visualization website where you can look at cancer incidence by state, or if you use the AIN module, by IHS region. And sometimes if you look at it by state, you'll notice that the AIN cancer incidence rates are lower than what you might see on the AIN module. And that's because for the regular USCS data viz, they do incorporate the IHS linkage in the race recode, but they do not restrict to purchase referred care delivery counties or to the non-Hispanic AIN population. So that's the biggest difference between if you look at AIN data by state versus our AIN module. The other difference is that there are some states that opted to not present their AIN data because of small counts issues, and those are Illinois, Kansas, New Jersey, New York, and North Dakota. Whereas for our AIN module, we were able to include all states because those states were okay with us aggregating our data with other states. They just did not want their state-specific data to be available. Okay, I guess we'll pause for a poll everywhere question.
All right. How are they doing on this first one? All American Indian Alaska Native cancer data is accurate.
Correct. False.
Great.
I'll continue the presentation. Okay, the next slide is cancer incidence means the number of new cases for a given cancer. I'm not sure how much time we give for these, but
Oh, about 15 seconds.
okay.
All right. How are they doing on this next question?
Good. So the answer is true. I'm not sure if everybody sees what I see, but
Oh, they do. They do.
okay, good. The next slide, I think it's one more question. Yeah. AIN rates of cancer are the same across the US.
All right. Looks like we're trending heavily on false. How did they do on this last one?
That's correct also.
Great. And we'll go ahead and open up that question slide and we'll post the link to that again. So if anyone wants to start sharing their questions now, we'll be ready for that at the end.
Okay, great. So we will keep trucking on here. So I'm going to go over the USCS data visualization tool, the AIN restricted to PERCDA only module. So currently, this is what our USCS data visualization website looks like. To find the AIN module, you just go to At a Glance and select AIN restricted to PERCDA only. And this is what you will see. We have a couple links if you want to share them, or if you want to copy this web address and email it to someone. But basically, our data are stratified, like I mentioned before, by the IHS regions. You can select which sex you're interested in looking at, and also the cancer type. And there's a bunch of notes here. We are currently working on uploading the 2017 to 2021 data. That should be available, I believe, in June. And we do have some other changes that are coming, I think, including this webpage moving to special topics, I think. But for now, you can find it under At a Glance. Now, this is as you scroll down the page, you'll see the section where they have AIN rates versus white rate. It depends on what area you're looking at. So if you select the East Coast, as I did for this, you'll see what the cancer incidence rates are in the East for AIN and the non-Hispanic white population. We do have some icons here, so you can look at data in the table or as a chart, and you can also download. If you're looking at the table, this version, it would export as an Excel spreadsheet. If you were looking at data, so if you were looking at a chart, it would export as PowerPoint. If you were looking at a table, it would export as a .csv file. And then towards the very bottom of the page, we have whichever cancer type you selected shown for all the different regions. So this is the cancer incidence rates for all new cancers across the IHS regions. So this shows you that the AIN cancer incidence rate for all cancers is highest in the Northern Plains, and then the Southern Plains and Alaska. Cancer incidence rates were lowest in the Southwest. And then also what the non-Hispanic white incidence rates are in the darker blue bar. You can also, show the 95% confidence intervals if you wanted, and also hide the non-Hispanic white rates if you were interested in doing that. At the very bottom of the page, we do have footnotes, tons of footnotes. We spent a lot of time on this. So this shows you which federal register we're using to identify the IHS purchase referred care delivery area counties, and then, which is down here. There hasn't been a change since the 2020 list, so we'll still be using that with the 2021 data. I haven't checked 2022, so I'm not sure if there have been any new counties added, but for now, we're still using the 2020 list. There's also a definition of the different regions, which states were included or excluded based on publication criteria, stuff like that. Almost everything you need to know is in these footnotes and within the links. So here, we talked about all the data all the stuff that we've done to try to improve AIN data. But I've also helped out with tribal linkages, in particular with the Intertribal Council of Michigan. And I think this paper that we published was really interesting because we did an independent linkage with one tribe in Michigan, and these are the results. So for 1995 to 2004 data, the Michigan Cancer Registry was able to identify 569 cases that were AIN. And then we did the IHS linkage. And we were able to find 502 65 cases that were not identified as AIAN by the Cancer Registry, but did link to IHS. And then we linked with the one tribe in Michigan, and we found an additional 168 cases that were not identified as AIN by the Cancer Registry or through the IHS linkage. So these are individuals that have never accessed IHS for healthcare. So we were missing them when we did the IHS linkage. And it kind of gives you an idea that we're probably missing a lot of folks who have never been to IHS. IHS only has individuals who are from federally recognized tribes. So they're only in that data set if they were, one, federally recognized, and two, if they have actually been to IHS. If somebody is never registered with IHS, we wouldn't capture them through our IHS linkage. So here are some of the data dissemination strategies that we're using to try to get our data out there. This is one thing we used our USCS AIAD for, and that is a report for cancer among the Navajo. So far, we've published 3 of them. The third one recently came out, and that was looking at data from 2014 to 2018. The reason why we cut off at 2018 is because after that time, the New Mexico Tumor Registry's agreement with IHS expired. So there was a bit of a gap in data capturing, which is why we ended at the 2018 diagnosis year. Once they catch up with 2019 to whatever year we decide to end on, we'll have another report. But we use data from USCS, the AIAD, so data from the Arizona Cancer Registry, New Mexico Tumor Registry, and then we also used US mortality data. So we had incidence data and mortality data in the Cancer Among the Navajo report. The other kind of report that we did was looking at cancer among the Haudenosaunee, or people of the Longhouse. This data set, we utilized the USCS AIAD and the USCS AIAN mortality database. We kind of have a side project where we link IHS to the National Death Index so that we can have improved mortality data, and that's what the USCS AMD is. For the Cancer Among the Navajo report, we used the general U.S. mortality data set, and that's because there was very little racial misclassification in the Southwest. So we felt comfortable using just the general U.S. mortality data. But for this data set, because of racial misclassification, we ended up using the USCS AIN mortality database. And what we did for this report is that we restricted our analyses to the counties that comprise the Haudenosaunee territories. So IHS has all these dark orange counties identified as PERCTA counties, but the Haudenosaunee felt like the ones that are in purple were the counties that comprise the Haudenosaunee territories. So those are the counties that we restricted our analysis to. Other things that we work on are USCS data briefs. We have one that comes out every November. You can find, using this link, a lot of the data briefs that we put out. We have quite a few AIAN ones. It's just like a quick front one pager of just data highlights. I think the last one was for gastric cancer. I'm not sure what our topic is going to be for this year, but we will have another one coming out in November. We've also done AIN Cancer Data 101s for the tribal epicenters. So basically talking about our IHS and PCR SEER data linkages, how we do the race recode, cancer site groupings, and different cancer data sources. And then also give an update on the IHS NDI linkage, because we like to use improved cancer incidence and mortality data when we work on our analyses. We have some manuscripts that are currently in the works. We have a kidney cancer one that was accepted but hasn't been published yet. And we're also working on a bunch of mortality papers. So we did link for 2020 IHS to the National Death Index, in particular because everyone was interested in COVID mortality. So we have 6 papers. Well, I think it's actually 8 papers that are coming out. So we have 3 that are coming out that are looking at the leading cause of death for 2020. We have it aggregated in one paper by IHS region, and another paper by IHS area, and also for the urban AIN population. And the same 3 groups for the COVID mortality paper for 2020. So IHS region, IHS area, and the urban population. This is the first time we've ever published data by IHS area. It's been something that has not been, we've kind of avoided because of one area in particular identifies a tribe, but we've gotten a lot of pushback from the community and also from IHS about how aggregating data by IHS area would be more helpful for them than using the bigger regions. So that's why we've started adding IHS area as a geographic variable within our data sets. So that's going to be the first time we ever publish anything by area. Once we get these papers out the door, then we'll start working on cancer incidence papers again. So these are 2 supplements that have covered our big IHS linkage projects. In 2007, we published a cancer supplement looking at cancer among the AIN population. So that included data from our IHS MPCR-SEER linkage. It's a publication on the right-hand side, fairly old, but it does cover our methodology and a lot of the cancer papers or cancer sites that were of interest to us. And on the left-hand side, we published another supplement, this one including results from our IHS NDI linkage. And also for the cancer papers, the IHS MPCR-SEER data linkages. So some of the helpful things that we got from the most recent AJPH mortality supplement was life expectancy at birth. So we were able to grab data for non-Hispanic AIN, non-Hispanic Black, non-Hispanic White, and just Hispanic population in general. And what we found was that life expectancy at birth was lower in females and males for the AIN population when you compared it to other race groups. Then we also looked at the top 10 cancer causes of death for AIN males. The top one for all the regions were lung cancer, followed by colorectal cancer and prostate. Stomach cancer kind of floated up kind of high for Alaska and also the Southwest, but was lower in other regions like the East or the Southern Plains and Northern Plains. So we found some interesting patterns when we looked at cancer mortality. For trends, we found that the AIN male rate appeared to be stable, whereas the non-Hispanic white male rate was decreasing. And we also looked at cancer causes of death for females. And again, lung cancer was the leading cause of cancer death, followed by breast cancer, and then colorectal cancer and pancreatic cancer. Stomach cancer was kind of high for the Alaska, but lower for Northern Plains, Southwest, Pacific Coast. So differences in different cancer mortalities for the across regions. And we also looked at trends. So the non-Hispanic white female mortality rate appeared to be stable from 1990 to 2009, but the AIN female rate was significantly increasing from 1990 to 2009. So it'll be interesting when we have our full USCS AI AMD data set ready. It will have data from 1990 to 2020 to see what is happening with cancer mortality. So in conclusion, we know that racial misclassification can be addressed through data linkages to provide better data. Our limitation is that IHS only covers about 53.5% of the AIN population. So we're missing a huge portion of our population. And tribal linkages will help us meet the gap, I guess. So I don't know if anybody has any questions. And here's my contact information. Okay, it looks like we have a question about Asian Pacific Islander populations. You know, I don't much work with the API population. I know within the cancer registries, we have very specific groupings, but I don't know how they relate to what's available on census. So I'm not sure how specific the API populations can be reported.
All right, and we did just have another question come in. Do you foresee a future with the non-IHS AI-AN population linkage being made?
So our bread and butter has been the IHS linkage, and that's because that is the largest known data set of AIAN. And because it's also collected by the federal government, it was fairly easy for us to get access and permission to link IHS to the cancer registries. I don't know of any other non-AIN data sets available. Like I said, the Intertribal Council of Michigan did get buy-in from several tribes in their state to do tribal linkages, and I've helped them do that. We've only published papers, I think, on three papers on those linkages, but that is something ITCMI worked on themselves. So they got permission to do those tribal linkages. I just went there and just helped out with the actual linkage portion because I didn't, as long as the data was updated for the state, that's all we needed. But there's definitely, that is definitely, I guess, the best way to capture the non-IHS AIN population.
Great, thank you. And Melissa, the questions just keep rolling in. This is great. In states with large non-federally recognized tribal populations like North Carolina, do you have thoughts or suggestions for what we should be doing to ensure better capture of their data? You mentioned tribal rolls registers as one example.
Yeah, I think that is a good way to capture everyone that is AIN who may not be accessing IHS. We also have done a linkage with the NTR, Northwest Tribal Registry Group. So Northwest Portland Area Indian Health Board has a project called the Northwest Tribal Registry, and they have a data set that they collect from different clinics, I guess urban clinics, the SP. I can't remember which data sources, but we did do a data linkage between their clinical data set and our IHS data set. And we did capture, I think, about 7,000 individuals who were in their data set that weren't in ours, and did include them for our National Death Index linkage. But that's another idea, is to use urban AIN data to link with the state.
Great. Thank you, Melissa. Another one for tribes that are not federally recognized, what national data sets would you recommend to estimate incidence, mortality trends, et cetera, regarding cancer?
That's a hard question because I will own up to the fact that I know that our incidence rates for the East are probably still underestimated because of a lot of the tribes in the East or Nashville area are not federally recognized. So far, what we have available on the USCS DataViz AIN module is the best thing we have right now. But we do always note that our limitation is that I don't feel like we're capturing as much data as we could for the East because of state recognized tribes.
All right.
And other than trying to link with those state recognized tribes, I'm not sure how we could try to improve that nationally.
Thank you. I always think that the best presentations often get the most questions, and you're getting a lot. I have several I haven't even put up yet. How open is the population in general to providing data for these collections?
How open is the population? Meaning the tribal population?
I'm sorry, I don't know if the person who shared that would like to go ahead and share more about that. That would be great. We'll move on to the next question. What advice would you give AI/AN cancer researchers who work in the global communities that are not federally recognized for data-related needs?
I guess I would encourage them to try to work with the states. Because, you know, we have a national data set, but it all comes from the states. So there are some states that work better with the tribes in their areas. In particular, you know, like I mentioned, New Mexico Tumor Registry, they have they call it a three-way agreement between New Mexico Tumor Registry, the Arizona Cancer Registry, and the Navajo Nation. So they are making, you know, specific strides to make sure that they're capturing as much of the AIN cases in the Southwest as possible. And also the Alaska Native Tumor Registry is doing the same thing for their population. SEER also funds the Cherokee Nation Cancer Tumor Registry. So they're capturing data for the Cherokee Nation. And then Cherokee Nation shares data with Oklahoma State Cancer Registry. Alaska Native Tumor Registry shares data with the Alaska State Registry. So it's all about relationships and making sure that, you know, the registries understand the AIN population, basically. Almost every year I go to the North American Association for Central Cancer Registries conference and do a talk about the AIN population, just so that, you know, the registries know why they're doing the IHS linkage, why it's important, and continue to provide support and continue to do them. Some do ask how they could improve their AIN data in other ways. In particular, that's what Michigan did. So Michigan worked with the Intertribal Council of Michigan to try to increase the AIN cases they are capturing. So doing the tribal linkage registry or tribal linkages in their state.
Thank you. And Dr. Emerson, do you want to read some of these as well?
Sure. All right. So from Michael Newcomer, we have a question. Do tribal health departments keep their own data sets, such as colorectal cancer incidence mortality for Eastern Band Cherokee?
Yeah.
Yeah.
So the states capture their own data. They have data variables that they don't pass on to CDC or in the data submissions. Just like I know for Michigan, they had a state specified field where they captured the tribal linkages. All they did was just did a race recode and submit it nationally for us, but they knew like which of their cases linked to which tribes and which ones linked to IHS. So they internally kept an had an idea of where they were capturing their AIN cases, but that's something that we don't see on our end because we only ask for specific variables to be included in our USCS publications.
Great.
Thank you. Let's see, we've got one great presentation, Melissa. Thank you for all the work you do for Native peoples. I have a couple of questions. As treatment becomes more sophisticated, how do those factor into your analyses? Anyway, on NN approval, are any analyses done on rare or novel cancers showing up among AIANs?
So treatment has become more sophisticated. And like I mentioned, for our NPCR registries, most of them are trying to capture cancer incidence. So they don't follow up cancer cases to find out what type of treatment they're seeking. That's something that SEER does. So that's kind of our gap and what we're finding out when I think my colleague Stephanie Melkonian was trying to look at breast cancer treatment. And that was one of the things she encountered, was that within our USCS data set, we didn't have a lot of treatment variables that she needs. So she's trying to figure out how we can report, AIN breast cancer treatment stuff within our data set when we're not capturing everything, or the states are not reporting all of those variables. So she's also looking at SEER data to try to see, what they can find through SEER data. Because SEER is is better at capturing treatment data than we are, since they're following cases through their entire lifetime. I don't know what the headway on NN approval is. I think that's Navajo Nation, but I'm not sure what that question is referring to. What's the next one was? So we are restricted on rare and novel cases just because of total case counts. Even when we look at cervical cancer, we run into small counts issues. So we can't look at very rare cancers for the AIN population.
All right, another great question. Do you have any experience linking your data with the Veterans Health Administration?
No. So that has been an interesting story. The VA used to report all their cancer cases to the cancer registries, and then there was some type of VA data theft. And after that, they started not sharing their data. So some of the states have their own agreements with the VA to capture all the cancer cases that are in the VA that they are not getting. And this year, they finally have an agreement where VA is going to send all their cancer cases to the cancer registries. So we kind of had a hodgepodge thing going on, and we hadn't identified which states weren't reporting VA cancer cases or not. And because there's a large portion of the AIN population that are part of the VA, we weren't sure if we were missing AIN cases or not. So I think now that the VA is going to be sharing cancer data with the registries, we should have a better picture of what was happening for the last decade when we weren't sure that all the registries were getting cancer data from the VA.
Thank you. Dr. Emerson, I'm going to take the next couple.
Sure. Okay. So I know that the North Carolina Commission on Indian Affairs is very interested in ways to address racial misclassification on health data. So, I think that just as a comment, maybe thinking about potential, collaborations and outlinks there as well. So we have a question, more information regarding my previous question. A lot of populations are hesitant to share their data, right? So this links back to, I think, when we're thinking about kind of tribal level information sharing, are hesitant to share their PPI. Is there also hesitancy with this population, or is it mandatory reporting if they are a federally recognized tribe?
So the reason why we link with IHS is because that IHS does have all that PII, and once we were able to get approach the IHS National IRB for our project, we were exempt from that because of we were trying to do surveillance activities. So we were able to do the IHS linkage fairly easy. Now, that's not something we could try to do with each tribe. First of all, I don't feel like it's our role to try to start those conversations. That is something that the tribe has to initiate on their own. And that's why we realized the Intertribal Council of Michigan was the one to approach the tribes and also their state to get all those agreements in place before they were ready to get help with the actual data linkage.
And then maybe we have time for one more. I know we're coming down to the top of the hour, but yeah, so great. Also, agree with the excellent informative presentation. Thank you. On the treatment tracking front, any thoughts about linking NPCR data to insurance claims, especially Medicare, Medicaid, for those AIN not receiving care through Indian Health Services?
Yeah, so the cancer registries do, so it's kind of IHS, if there is a diagnosis of cancer, often patients are referred out. Once they're referred out, that's where the cancer registries kind of pick up start off on their end, because they have data sharing agreements with pathology labs and also any cancer centers. So they collect case information that way. And I know there's a big gap in that treatment stuff isn't fed back within IHS, but the cancer registries are often able to capture any information once people are referred out of IHS. We link to IHS not for any additional medical information, but just as a purely identifying AIN or not when we do our linkage with the cancer registries. But the cancer registries are linking to several different data sources to capture as much information as they can on their end. They just may not have good race information.
All right. Well, Melissa, thank you so much. This has been wonderful. Oh my gosh. Just want to remind folks, SAICEP.org, www.saicep.org. Please visit the site. This is a collaboration between Duke and UNC Lineberger Comprehensive Cancer Center and Atrium Health Wake Baptist Forest Comprehensive Cancer Center. We want to remind folks of the self-paced lectures that are available. So you can go and watch the videos there. You can also receive credit if there are applicable types of professional education credit available to you for these. Please feel free to do that. And there's all no cost to any of the participants to do this.